Hi, my name is Harsita Patel. I'm a paediatric trainee and I'm currently working as a research fellow at Imperial College London, studying SARS-CoV-2 associated disease in children. And here with me today is Dr. Jethro Herberg, who's a clinical reader in paediatric infectious diseases at Imperial College London. Jethro has a special interest in Kawasaki disease, and today we'll be having a discussion about the acute management of this condition. So to start off, I'd like to ask Jethro, why are you interested in Kawasaki disease?
So, Kawasaki disease is an enigma. It's one of the big enigmas in paediatrics. We don't know what causes it, and we don't know how to diagnose it with a good test, and there's lots of questions about management. So it's a really burning question. But it's also a really clinically important question because it's a disease that causes the highest rate of acquired heart disease in children. And children with Kawasaki disease can be left with damage, particularly to their coronary arteries, that can be a ticking time bomb for their whole life. And this is not a problem that we can't do anything about, because we know if we recognize and treat Kawasaki disease early and effectively, we can reduce this burden. So it's a clinically highly relevant disease. It's not so rare, and it needs to have optimal management. So it's really important to get that message across to my colleagues, I suppose.
So how can we make the diagnosis of Kawasaki disease?
So making a diagnosis of Kawasaki disease is difficult because there isn't a diagnostic test that we can use at the moment. The textbooks and the Kawasaki disease guidelines describe a classical set of features in combination with prolonged fever. And they are important to know because they can help you make the diagnosis, but they're not sufficient to make the diagnosis in everyone with Kawasaki disease, and they can distract you from patients who've got Kawasaki disease who are being missed. The features are traditionally 5 days of fever, and I'll come back to the 5 days, plus at least 4 out of 5 of having conjunctivitis, inflammation of the oral mucosa, adenopathy, rash, or inflammation of the hands and feet, typically red and swollen in the early part of the illness, and then later on that you can get skin peeling. The message I really want to say is that Kawasaki disease does not fit to a single type, and that every patient comes with a slightly different set of symptoms, some of them present, some of them not present, and often with other symptoms besides. So you have to have a high index of suspicion to catch this disease. And that's really important because it's the delay in recognition and diagnosis that makes the disease so bad. Alongside the fever, I think an important feature that people can look out for is the fact that if you've got a child with high inflammatory markers who isn't responding to antibiotics, you have to ask yourself, why isn't this child getting better? Have they really got some obscure or particularly nasty infection, or could it be the case that they've got an inflammatory illness? And I think that in the current era, with lots of effective vaccines available, the likelihood if you've got a child not getting better with antibiotic treatment, with a fever, with high inflammatory markers, the likelihood that they've got an inflammatory condition and not an infection is getting bigger and bigger. And so all clinicians who see children have to be ready for not if, but when they're going to see their next case of Kawasaki disease. And the group where we particularly fail to make a diagnosis quickly are the under ones, and they're also the group where it's quite common not to see all of these features present. So you have to have a high index of suspicion when you see a child with fever, particularly if you're seeing a child with fever and a high inflammatory markers who's not getting better with antibiotics. You really have to start thinking, is this an inflammatory illness? Could this be Kawasaki disease?
So you said 5 days of fever might not necessarily be needed for the diagnosis. Could you tell us a bit more about that?
Absolutely. The classical description of Kawasaki disease was to have 5 days of fever plus certain other features. We know that if you treat Kawasaki disease earlier, you're more likely to have a good outcome. And in parts of the world like Japan, where Kawasaki disease is more common than it is in the UK, the median day of diagnosis is less than 5 days of fever. And we should be sending a clear message that you do not need to wait for 5 days of fever if you've got strong suspicion of Kawasaki disease, because you can actually start treatment and prevent damage. So the earlier it is in the illness, it's true to say, generally speaking, that maybe that you're still at a point in the child's illness where there's a broader differential diagnosis, but you have to start thinking about it, and you certainly should not be waiting for 5 days before you feel you're entitled to make a diagnosis.
So Jethro, who's affected by this condition?
So Kawasaki disease is a disease of children, and there is a peak in quite young age. But I think it's important for people to be open to the idea that any child they see coming in with a fever may have Kawasaki disease. So I want to give the message, Kawasaki disease is something that can affect all ages of children, all races of children, boys and girls. And there are some differences, but I think they are not important at the point of making a diagnosis.
And while there's no diagnostic test for Kawasaki disease, are there any other blood tests that may support its diagnosis?
So Kawasaki disease generally, though not always, is associated with high CRPs, typically above the 100 milligrams per litre range. It's commonly seen with a neutrophilia. We can also see a low hemoglobin, a low albumin, which goes down as the illness sets in. We see platelets can be low in the early part of the disease, and then they can get to a high level later on in the disease. None of these things are particular only to Kawasaki disease, but they can be clues to help you think about it, but they certainly don't differentiate Kawasaki disease from other important differential diagnoses.
What are some of the important differential diagnoses that clinicians should consider when a child presents with these features?
I think you can think about Kawasaki disease as a child with a high fever and high inflammation. So there's a long list of differential diagnoses. In particular, there are a few conditions which actually mimic those classical clinical features of Kawasaki disease. So for instance, in terms of infections, bacterial infections with group A streptococcus or toxic shock syndrome can mimic Kawasaki disease. And there are viral infections that can mimic it too, particularly measles and adenovirus. Plus, there are additional inflammatory illnesses, and an important new kid on the block in the last couple of years has been pediatric inflammatory multisystem disease associated with coronavirus infection. And that's also an inflammatory disease which can also involve the heart. So Harsita, it's nice to have you here as you're an expert on another illness that we've mentioned, which is PIMS-TS. Can you tell us what is PIMS-TS?
Sure. So PIMS-TS is pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2. It's a new condition that we've seen following the COVID-19 pandemic, where children have presented with persistent fevers, rash, conjunctivitis, abdominal symptoms. So some similar features to Kawasaki disease. So we've seen lots of similarities, but there are also distinct features. So on clinical presentations, we know that in PIMS-TS, there's a prominence of gastrointestinal symptoms, for example. The epidemiology is also slightly different, with older age groups being affected in PIMS-TS, usually around 10 to 12-year-olds. And research studies looking at gene expression or immunophenotyping have shown that, well, there are similarities, that actually these two conditions are very different, and it's important to bear this in mind.
So when we have a child who's got an illness which we think is inflammatory, they can, as you've said, be distinguished sometimes if they've got PIMS-TS or Kawasaki disease. In the younger age group, it's quite difficult. How do you go about deciding on treatment if you're not sure?
So the principles of treatment in PIMS-TS are based on reducing that overwhelming inflammatory response that you're seeing in the acute period to prevent cardiac complications, which are slightly different from Kawasaki disease. So we don't get coronary artery involvement. Children tend to develop cardiogenic shock, requiring inotropes and intensive care. And to prevent that, the principles of treatment are actually quite similar, so based on immunomodulation. And studies have shown that IVIG and steroids are of equal benefit for patients with PIMS-TS. So in that group of patients, the younger ones where it's unclear whether it's Kawasaki disease or PIMS-TS, it's recommended that we treat with IVIG, because we know that in Kawasaki disease, early treatment with IVIG prevents coronary artery aneurysms and other long-term complications. So if in doubt, give IVIG. If not, consider using steroids. Jethro, you mentioned that Kawasaki disease is the leading cause of acquired heart disease in children. Could you tell me a little bit more about the cardiac complications in this condition?
So Kawasaki disease is a vasculitis, that is, it's an inflammation of blood vessels, and it particularly goes for your medium-sized blood vessels. A particularly important set of medium-sized blood vessels are the coronary arteries that give your heart muscle its blood supply. And that is the point at which we are most interested in looking in Kawasaki disease, but it is not, I should mention, the only set of arteries that can be affected by Kawasaki disease. So in the coronary arteries, the damage can lead to distension of the coronary arteries, leading to aneurysm formation. The remodeling can later on actually lead to stenosis and inadequate blood supply to the heart muscle. So coronary arteries are a particular site of concern in Kawasaki disease, but it actually affects all layers of the heart muscle, and you can get a myocarditis and a pericarditis too, and you can also indeed have valvular problems. So it's a pan-cardiac disease. The involvement of the heart, though, is really what drives the need to treat and diagnose Kawasaki disease quickly, because the quicker you get in there, the less likely you are to get coronary artery damage. And therefore, careful examination of the heart is an essential part of the workup in Kawasaki disease.
How important is it to get an early echo in the management of Kawasaki disease?
The first thing I want to say about the role of echo is that you don't need to have an abnormal echo to make a diagnosis of Kawasaki disease. So you should be expecting to make a diagnosis often without having had the benefit of an echo. And secondly, if you do get an echo and it's normal, it doesn't mean the child hasn't got Kawasaki disease. It means you're doing well because you're treating before there is visible damage. And therefore, an echo should not be seen as an essential part of the diagnostic criteria. However, it's a really important investigation to be done early in Kawasaki disease because it does help you seal the diagnosis if you find changes, but more importantly perhaps, it allows you to stratify your Kawasaki disease patient according to what's going on. If there's significant coronary artery involvement, you may need to be thinking about additional treatments earlier, including, apart from anti-inflammatory treatments, which we'll come to, also maybe treatments to prevent blood clotting. So echo is important early in the disease, shouldn't be relied on for diagnosis, and it's one modality of imaging alongside other things such as CT, which are important in stratifying the patients. I should also mention that an ECG can be helpful as well early on.
What is the epidemiology of Kawasaki disease?
The epidemiology of Kawasaki disease is fascinating because it's very different in different parts of the world, but I think the clear message I want to give here is that Kawasaki disease is not restricted to one sex, it's not restricted to one age group, and it's not restricted to one ethnicity. We see Kawasaki disease from first weeks of life through to older children, even teenagers. And Kawasaki disease can be missed because people have a preconception that it can't be relevant in the child they're seeing. That's just not true. We know that because of the difficulties of diagnosis and because of the fact that people are not expecting to see it, we often make the diagnosis late and treat late, with the consequence that we have a higher rate of aneurysms than we should. And the BPSU study found that 19% of children with Kawasaki disease had a diagnosis of aneurysm or coronary artery damage after their illness. And even more shockingly, in the under ones, the rate of coronary artery damage was 39%, which is incredibly high. And we can really change that by being better able to recognize the disease more quickly and being ready to treat it optimally.
Why is there often a delay in diagnosing Kawasaki disease?
I think the delay in diagnosis is very much about people not expecting to see Kawasaki disease. and people failing to understand that it's actually not such a rare condition. There's also a tendency for people to make a diagnosis of something else and stick with it. And I think an important message from this discussion that I'd like to get across is that if you have a diagnosis such as meningitis or a measles infection or group A strep infection, all of which are incredibly reasonable differential diagnoses for the symptoms you see in Kawasaki disease, you must keep thinking, is this the right diagnosis? Could it be Kawasaki disease? Because most patients arrive at a Kawasaki disease diagnosis having initially been diagnosed with something else.
If you find a cause for an infection in a patient with Kawasaki disease features, does that mean that they don't have Kawasaki disease?
It doesn't mean that they don't have Kawasaki disease. So, to the contrary, in fact, we often do find pathogens that can cause disease in patients with Kawasaki disease symptoms. And it may not be entirely independent. We don't know what the cause of Kawasaki disease is. It could be that there's a single pathogen trigger. There may be multiple triggers in different people. There may be environmental triggers. So, first of all, yes, you can have an infection and Kawasaki disease, and we quite often see that. And secondly, it's even plausible that there may be some sort of causal link between a patient who appears to have an infection and is then followed by an illness that becomes more Kawasaki disease-like and turns out to be Kawasaki disease.
Jethro, you've emphasised the importance of early diagnosis and prompt treatment. What are the treatment options for Kawasaki disease?
You should start the patient with treatment with intravenous immunoglobulin, IVIG. We give 2 grams per kilo, it's a long infusion, and there's good data to show that this can reduce the risk of aneurysm formation as long as you give it early in the illness. The second treatment, which is also standard, is aspirin. Aspirin is actually given at different dosages by different places. At a lower dose, it perhaps has a slightly more beneficial antiplatelet effect, but at a higher dose, you also get the benefit of an anti-inflammatory action. So all patients get IVIG and get aspirin, though the dosage can vary. Now, there are other things we could also consider giving as a first-line treatment. There's particular interest in giving steroids alongside IVIG in the initial treatment. And there's been a number of studies of this, particularly in Japan. And indeed there's a trial ongoing in Europe called KDCAP. And we're waiting for the results of that because I think it may help us determine whether or not it goes into the textbook as a standard adjunctive treatment at the beginning.
Do you have any advice for clinicians who might not be as experienced in managing Kawasaki disease and are struggling to strike a balance between early diagnosis and treatment versus overdiagnosis and inappropriate treatment?
You're right, you're hitting upon a really difficult thing. I'm interested in Kawasaki disease. I see things through a lens of Kawasaki disease. I'm very keen to give a lot of patients who I think have got Kawasaki disease early treatment with IVIG and aspirin. IVIG is expensive. There's a shortage internationally, and it's a blood product, so it's not something we throw around. And you have to be confident that you're using it appropriately. On the other hand, if you delay diagnosis, or you delay treatment, rather, there's a risk you're putting that child at risk of a lifelong cardiac problem. The thing about IVIG is that although it modulates your immune system and helps reduce inflammation, it doesn't actually shut off your immune system. If you are making a diagnosis of Kawasaki disease at an early point in the illness, there's probably a thought process in your mind still about, is it Kawasaki disease or could it be one of the infectious differentials? And at that point, giving powerful immunosuppressive drugs may be seen as risky. IVIG does not have that disadvantage. So in the interest of not doing your patient any harm, it's a great first-line treatment because you can give it if you think there's a reasonable likelihood that someone's got Kawasaki disease, even if you haven't closed off the possibility that they've got a differential diagnosis.
How would you assess if a patient is responding well to your first-line treatment?
A child with Kawasaki disease will have a set of clinical features. They'll have abnormal blood tests. They'll probably be very irritable or have fever. there's no one of those things that is better when the child responds to treatment. They all have to be better. So this is an important point, I think. You've only responded to your first-line treatment if all the clinical features are either better or quickly improving, if the irritability is gone, if the fever has stopped, and if the blood tests are either normal or are on a sharp gradient down towards normal. If any of those things don't apply, then you need to be thinking, okay, do I need to give something else? And that isn't a rare situation. A good 20% of our patients do need to have second-line treatment, and you do want to go in there quickly if you think that there hasn't been a full response to your first-line treatment. This is a moment in this child's life, which if you get it wrong, can lead to a lifelong problem. And for me, there's an overwhelming balance in favour of hitting hard, erring on the side of aggressive anti-inflammatory treatment to avoid a lifelong problem.
And what sort of agents are available as second-line treatments?
I'm going to start the answer to this question by saying I think what's less important than what you give is that you give something and you give enough of it, and if it doesn't work, you give something else. Okay? So what you want to make sure is you've shut off the inflammation. How you do it is probably less important than what you use. So steroids, anti-TNF drugs like infliximab, anti-IL-1 drugs like anakinra, and anti-T-cell drugs such as cyclosporine are all used. They've all got trial evidence for them, and depending on what's available in your centre, there may be reasons to use one drug first before the others. It is worth pointing out that there is a familiarity that people have with IVIG that means that they're comfortable to reach out for that. IVIG is the most expensive of all of the options. It's also the drug that's in short supply. It's also a blood product. So in general, in our use, in our practice, we generally don't use IVIG as the first-line drug for secondary treatment. We'd rather go on to a different type of drug.
So just to clarify, you can give a second dose of IVIG in Kawasaki disease?
You can. IVIG works through a not entirely clear mechanism, and it can completely treat the disease, it can partially treat the disease, or it can fail to treat the disease. And in some cases where it's partially treated the disease, a further dose will help. I would say that if it has worked less than perfectly, you're better off giving an alternative immunosuppressive drug, which will also be cheaper.
Jethro, what advice would you give to a clinician who's discharging a patient with Kawasaki disease?
I think an important message for doctors to give their patients is that they should expect to get better. This is a self-limiting illness that even if you do nothing to treat will get better, although it can leave lasting damage. So that all the nasty aspects of the condition when it first comes, including the fever and everything, should get better. It may take some time, but they will get better. The other things to think about are immunizations. IVIG can impact on how well you respond to vaccines, and we recommend delaying live vaccines for 6 months after IVIG. We also recommend delaying subunit vaccines for a few months after IVIG. Immunosuppressive drugs that they've been given can have a significance for the few months until they're washed out of the system in terms of susceptibility to, for instance, measles and varicella. And the important thing to make sure before someone goes home after Kawasaki disease is that there's robust cardiology follow-up in place. That's the cornerstone of good after Kawasaki care, is to make sure that the heart is being looked at with an echo, at least normally in an uncomplicated Kawasaki case at 2 weeks and 6 weeks, and then with follow-up to at least 6 months or a year before it's possible to discharge the child. So for the most part, we do expect most of our patients to be discharged with a clean bill of health.
Where do you see the management of Kawasaki disease going in the future, say 10 years from now?
Well, I think we will have a diagnostic test for Kawasaki disease in the next years to come. And I think that can really make an impact on early diagnosis and early treatment and prevention of the burden of cardiac damage that we see at the moment. Alongside that, there's a lot of work going on to define optimal first-line treatments, optimal second-line treatments, and also adjunctive treatments that may help reduce the remodeling, the negative remodeling of normal coronaries into damaged coronaries. So I think there'll be information coming in from studies over the next years, and I'm looking forward in 10 years' time to seeing our Kawasaki disease protocols maybe looking quite different with new drugs in that can help our patients.
So I think the key take-home messages for me would be that clinicians should maintain a high index of suspicion, and this would ensure early diagnosis. This leads to prompt treatment, which we know reduces the risk of coronary artery aneurysms. And finally, if a patient is not responding, it's important to consider second-line treatments and start them early.
Thank you, Harsita. I absolutely agree. I'd like to close by also signposting people to the website for Society, who've got a fantastic array of educational materials, both for doctors and for patients and families with Kawasaki disease. And my final message is, this is not a rare disease. Clinicians dealing with frontline pediatrics need to expect to see a case and need to be ready to treat it because they're going to see one.